Good day, everyone. Welcome back to this session. Our next topic will focus on respiratory risk and breathlessness in telehealth care. Let's review what we studied in our last session. In that session, we talked about functional decline. We learned that functional decline in telehealth may indicate worsening cardiovascular reserve because physical examination is limited. It is seen as reduced ability to perform usual daily activities. We also discussed about symptom trajectory, and we learned that trajectory means how symptoms change over time. It is more important than a single report because worsening symptoms suggest higher risk. We also discussed when to escalate. We explained that escalate care when there are red flags, worsening symptoms, functional decline, or uncertainty that cannot be safely managed in telehealth. Let us now dive into the main discussion for this session. Respiratory complaints are among the most common and most dangerous presentations in telehealth. Breathlessness can represent anything from mild anxiety to rapidly evolving respiratory failure, pulmonary embolism, acute heart failure, severe asthma, pneumonia, and lastly, sepsis or silent hypoxia. The defining challenge is that telehealth removes key clinical inputs, which include direct observation, auscultation, accurate respiratory effort assessment, and immediate bedside escalation. In virtual care, respiratory risk is amplified by three realities: reduced sensory input, delayed rescue, and faster deterioration when assessment is incomplete. Many patients describe breathlessness poorly, minimize symptoms, or cannot recognize worsening until collapse is near. Others may look fine on video, while oxygenation is dangerously low. Advanced practice telehealth therefore requires anticipatory reasoning, interpreting breathlessness as a risk signal, using structured questioning to estimate severity, and escalating early when uncertainty remains high. This model equips nurses and midwives to assess respiratory symptoms safely in telehealth by using a structured remote respiratory assessment, recognizing atypical presentations, detecting silent hypoxia risk, integrating context and comorbidities, and applying defensible escalation thresholds. This model emphasizes on practical decision-making that protects patients and clinicians, when to manage virtually, when to convert to urgent in-person assessment, and lastly, when to trigger emergency response. We have come to the end of this session. Thank you for watching. See you in the next session.